متابعة واخا باش نقرب لي هذيك الصورة
حداك باش يحتاج شي حاجة.
Hello everyone, it's my pleasure to introduce this session about clinical case for adults with PID. My first clinical case is a case about a male patient, 67 years old, and he is a university professor of physics. He's very, very intelligent, and he's originally from the east of Morocco. He has a maniaco-depressive psychosis from 1988, and he was treated for hypothyroidism. He had a surgical history of thymoma B2 in 2018, and he has no family history. So he had a thymectomy in January of 2018, and it was classified B2 thymoma from the classification of Masao-Kakoga. And during his follow-up, he developed a lymphopenia, a severe lymphopenia, and he developed a sepsis from a pulmonary infection with high inflammatory parameters, procalcitonin and CRP. And during his course, he developed also hypogammaglobulinemia that was attached to the sepsis, to the severity of the sepsis, but he continues to present this feature along the way. He had many biological tests, many serological assay for HIV, hepatitis, Mycoplasma aspergillosis because he had a pulmonary feature, and all came back negative. We completed to search for a decrease in lymphocytes, and we noted that he has a decrease in T lymphocytes, NK lymphocytes, and B lymphocytes that were absent. So we have retained a diagnosis of Good syndrome. He has a thymoma, hypogammaglobulinemia that was absent in the earlier years of his history. And this immunodeficiency, he became very ill. He developed many pulmonary infections. Okay, so nowadays he come to our clinical setting to present with a deterioration of his general condition with weight loss, and he had also developed neutropenia and a CMV viral load that was not very positive. So he was maintained under intravenous immunoglobulin, Bactrim for antibioprophylaxis, and he was quite good until recently, when he presented with a persistent diarrhea above, it was three months of clinical course with diarrhea and malabsorption. The patient had stool routines with bacterial and parasites cultures which were negative. He had a colonoscopy which was suggestive of Crohn's disease. He had a CMV negative in his histology. He was treated by pentasa and salasoperin were recommended by his gastroenterologist. The clinical course was not very good, so he maintained his digestive problems. And when we see digestive symptomatology of Good syndrome, it's very frequent. It's almost 50% of patients. It can be related to bacterial or viral causes, but we can have Crohn-like disease with Good syndrome. So we are not very pleased with the outcome with our treatment. He was under pentasar, corticosteroids. We added corticosteroids, and he maintained his diarrhea with a deficiency in vitamin B12. He has also developed another pulmonary involvement. So with a persistent inflammation in his blood. So we did a PET scan, which was positive for nodules in his lungs. From the point of view of the nucleus, they said it can be a granulomatous involvement in the lung, but we have to be more careful for infectious disease, notably for tuberculosis, because we are thinking to propose biotherapy or biologics for this patient for his digestive involvement, but we have to be sure that he did not have tuberculosis or another infection in his lungs. So he is waiting for a biopsy, a guided biopsy. That was from Monday, this PET scan. Yes.
It's very fresh.
Yes, it's very fresh. So I am waiting for your suggestion or your comments.
Well, I have such a strong feeling about Good syndrome because Bob Good hired me for my first job. So he's somebody that I actually do know and have now followed 17 cases of Good syndrome, and we have been recently referred another 3. We've had several who developed extremely severe COVID and one who developed also endocarditis. And so our search is also for strange and unusual autoantibodies, because in Good syndrome there's a propensity to develop antibodies to IL-12 and interferon gamma and alpha interferon, and then that gives you a propensity to these viral infections. And that is something that, you know, I can put a name on it. I don't know what I'm going to do about it. I mean, the whole thing is completely strange. I mean, why do they lose their B cells?
Yes.
And so we are currently in the process of doing another study with somebody at Stanford who has a very open-ended protein-based proteomics array to say, gosh, I don't know what the antibodies here that are the bad ones, but what could they be? And so we are now on the search for additional autoantibodies because the ones that we do know are really causing trouble.
Yes.
It's an incredibly, it's still a mystery box. So if anyone wants to think about Good syndrome more, it's what the thymus does.
Yes.
And actually, we had a lecture yesterday, which I zoomed into with Diane Mathis at Harvard, who was talking again about how little we understand the thymus, to be honest. You know, like, why do miscellaneous tissues appear in the thymus to begin with, which they do? And how is it that autoimmunity is conquered, and what does this do? So for him, obviously, you wait the biopsy,
Yes.
and that's going to tell you what next. It's either infectious or it could be another tumor, I suppose.
Yeah. And if it became good or negative, we can use biologics in this case for.
I think you
involvement.
will. You'll try to choose something as targeted. The other thing is if you
TNF?
wanted to, you could also ask the NIH to run for you for free serum to say, tell me what autoantibodies are present in this sample that are the ones that they do test. And they can do that. I can give you the address.
Okay, thank you so much.
It's just a serum sample. They will have to consent the patient over the phone, but he's a smart guy. He will
Yeah.
understand.
Very smart.
Yeah.
You can do the same at the Imagine Hospital in Necker for the autoantibodies, and some
Yeah.
authors suggested that good syndrome is a result of autoantibodies against T cells and B cells. That's it's a whole immune mediated because it's late onset, very late onset immunodeficiency in link with the Timoma, but you have good syndromes without Timoma, and when you put off Timoma, the immune deficiency is automatic. It's not dependent from the presence or not of the Timoma, which is very puzzling as well. And as Mrs. Cunningham said, we are writing an article about antibodies against interferon alpha because indeed
It's a problem.
they had very severe SARS-CoV-2 infections.
You had some COVID infections? Interesting.
And very long infections. And I would like to ask you if you did a medullary biopsy to understand
Yes.
cytopenias.
Yes.
Because
Because,
aplastic anemia is
Yes, it was puzzling for us to have this severe anemia, and we did the medullogram, and it was good. It was just megaloblastic anemia,
okay.
and he increased his hemoglobin under the vitamin B12 supplementation.
Okay, which is related to gastric atrophy.
Yes, yes.
So it's
digestive
involvement.
involvement. Yes.
Because you have other medular involvement in Wood syndrome. There is a paper like 4 years ago.
With lymphoma.
No, it's aplastic anemia associated with Timoma. So it's very severe cytopenias, very resistant. It's Evans syndrome or aplastic anemia, very resistant to therapy, usual therapy, and we have a patient that had everolimus and cyclosporine and corticosteroids to normalize the cytopenias.
Okay.
It's very refractory, and we have as well a patient that died from neutropenia, prolonged, very sustained neutropenia.
Because he has
aspergillosis.
presented with neutropenia.
Yes.
It was very severe.
Yeah, and
Yes.
Interesting.
it's the usual feature, and
Maybe there was an anti-neutral antibody.
Maybe.
yes.
Just interesting to know what that was the basis of that.
You have
There may have been an antibody against intrinsic factor too, I suppose.
we
I'd
did
just
not
like to know,
search
what
for-
is his biggest problem aside from this new?
His digestive problems.
Digestive
he has
is
a
number one.
persistent diarrhea, and it's
What
very.
is the biopsy? I missed what the biopsy was.
It was Crohn-like.
Yeah, that
yes.
doesn't tell me. Tell me,
Mm.
please,
He
I hate
didn't
it when
have
the pathologist says
granulo-
inflammation.
Yes, he
Please.
didn't have granulomas or just.
T cells? B cells? No B's, right? T cells
they-
probably, right?
they-
CD8, CD4,
They don't go so far in our.
but you can ask them,
Yes.
you can ask them,
Yes.
tell them,
How
give me
many
some data,
yes,
please.
percentage of cells? Yeah, it would be interesting.
Yeah, Crohn's doesn't tell me anything.
Yeah. Yes. Okay. Thank you so much.
it's a very
Enlightening. Thank you.
very successful.
I mean, it could be something like, Avastin or benelizumab or something else. You could use something that's targeted if you knew what the cell was.
Yes. Would be very useful. I'll present my second case, and I'll let my colleagues. Okay, thank you. That's one patient very dear to my heart. She's a PhD candidate with us in the laboratory, and she's 25 years old, and she didn't have surgical history or medical history, but she has from 1 year her problems started. Her family history is very interesting because she got first degree consanguinity and she has a maternal cousin with a Crohn disease. So from age 1, she started a chronic diarrhea that persisted with her all her life. 5 years later, she's been documented with lung infections. She has a failure to thrive. And at the age 10, she was diagnosed Crohn disease and was unsuccessfully treated with sulfasalazine and corticosteroids. Her clinical course was, she maintained her diarrhea, and with the resurgence of pulmonary infections and otitis, occurrence with warts and in her hands, in her feet, lymph nodes, and some autoimmune symptoms such as posterior uveitis and arthritis. At the age of 13, she had bronchiectasis. She was assessed from the beginning for searching HIV for this severe lymphopenia that she had. That was negative. Thrombocytopenia with negative immunological assessment. And she had a protein electrophoresis that was clear for a severe hypogammaglobulinemia. The study of the lymphocyte subpopulations showed the complete absence of B cells and a decreased number of CD4. I think she was followed up for 25 years for this disease, and finally, this year, she had NGS, and she was diagnosed with a deficiency in LRBA gene. And with this result, we've chosen to begin abatacept treatment for specifically for her digestive involvement. She has diarrhea every day, and sometimes she had a severe hypokalemia. So it's a very, very severe clinical picture. And for the who doesn't know about LRBA deficiency, it associated immune deficiency, lymphoproliferation, and various organ-specific autoimmunity. So they can have autoimmune cytopenia, they can have rheumatic involvement. LRBA is thought to regulate the CTL4 protein, that is, it is an important inhibitor immune receptor. It was considered a common variable immunodeficiency-like disease, but knowing the course and the differences in the outcomes, now it is well individualized and tied with specific treatment. I think it was the first Moroccan case with this deficiency, and it was retained after 24 years of delay. We are waiting to see what abatacept can do for this young woman, and if you can come up with some
Can you get it?
details.
Yes. Will you be able to get it?
Yes, from abroad.
From
Abroad. We don't have it here in Morocco.
So she's paying the treatment?
Yes, yes.
Wow.
With the
Social security.
with the social security and the help of the Hajar Association.
Okay.
wonderful.
Yes.
Abatacept is really effective. We have about 4 patients in Egypt who have been diagnosed with LRBA, and they have different presentations. Some of them have cytopenias, others have GIT manifestation, and it really worked very well with them.
What's the dose? Are you
Yes.
using, and how frequently?
They take it on every 2 weeks, the injection, but I can't really remember the dose.
I guess it's 15
Yeah, it's a sub-Q.
Right. We haven't seen very much LRBA in the United States. We haven't seen very much. Patients
we don't know the long-term effect of this abatacept, when it will stop, if it has a carcinogenic effect or not. If these patients will develop another thing, this is a question that really we don't have an answer. But if they're stable, we just keep them because most of we have a problem that we don't have a donor bank. So if we're going to go in a transplant, it's going to be a haplo. And haplo transplantation in LRBA results are not really happy. Yeah, to go for it. So we are just, like keeping them and see how things will go. Yeah.
Because it's still relatively new.
Yes.
Right, but her biggest trouble is that she has, you said diarrhea, so that means every day,
Yeah.
completely loose stools all the time, more than one time a day, or what?
It's 3 or 4 times a day.
And with hypokalemia,
Yeah,
as you're saying.
sometimes, and sometimes she goes for 11, frequency of 11 times a day.
Okay,
Yes,
Getting up at
very
night as
severe.
well?
Yes.
yeah.
Yeah.
But you don't add with the abatacept any other immunosuppressants?
She's under corticosteroids, but it doesn't.
What about Pentasa
She was under
with the abatacept? Did you try
No,
adding both?
we didn't try it. We just began the abatacept to see how it will go.
Okay. But I think if she's still manifesting, you should bridge like with the Pentasa or
Okay.
something and then withdraw it and keep the abatacept because it takes some time to
To
work.
be effective.
Yes.
What is your other compound?
I'm sorry, Pentasa.
Oh, the pentasa.
You can use as well hydroxychloroquine. Is efficient. It was demonstrated in science in 2012 that plaquenil, hydroxychloroquine, inhibits endo and lysosome, and then force CTLA4 to be expressed. Okay, because LRBA deficiency is not the problem. Is that LRBA is the body of CTLA4, and then it's a CTLA4 deficiency like. That's the first. It can be useful to have plaquenil, hydroxychloroquine. And the second thing about our experience in abatacept, in CTLA4 deficiency or LRBA deficiency, it's very nice for diarrhea and IBD, but it's very disappointing when they develop, because they develop a lot of hepatic vascular sinusoidal disease, the liver disease, the vascular liver disease.
Gets worse. Veno-occlusive?
Veno-occlusive disease, yes. It's like it's more frequent in low SID form, low onset, and
And the abatacept is not helpful, or it
No,
makes it worse?
no.
Or what do you think?
it's not better.
It doesn't address it,
Yes,
does it?
and they die eventually from liver. It's for the discussion of the allo-HSCT. And it's very, we cannot predict at this time when it will happen. It's the more severe is the hepatic involvement.
What is the cause of that? We don't know.
We don't know. We are working about it, that's why.
What do you think? Make a hypothesis.
My hypothesis, our hypothesis in some way is that intestinal dysbiosis
It's part of the problem.
is part of the problem, probably, and
makes sense.
bacterial
Going
translocation.
from the liver up to the liver.
Yeah, because we have noticed that they all begin with diarrhea, and then they develop eventually the vascular liver disease. It's one hypothesis.
Sure.
It's not
Sure.
the only one, but that's so. I guess it's very urgent. It's very important for her to have abatacept before she
Develop
moves.
an
Yeah.
liver problem.
But I guess you should be very careful because sometimes liver disease is very mild, so you
have to search for it.
you have to search for it. You know,
Maybe she needs a biopsy. I don't know. What do you think?
she needs a CT scan to see
scan.
if there is a splenomegaly or derivation. Portal hypertension, signs of scanographic signs of portal hypertension. And if she has any liver abnormality, impairment in the enzymes, I guess that biopsy is.
And how do you treat it?
Liver
Why don't we use
transplantation.
more budesonide under the circumstances? It is used for autoimmune liver disease. Why don't we do that?
to how many years?
How many years? Yes, it's an excellent question. What is difficult is that the diagnosis is very late in the literature. So we notice that the patient has a liver injury when he's with ascites and
Complications.
so theoretically it's 15 to 20 years, but I guess it's shorter than that.
But we don't have that much history on the abatacept treatment. Maybe that slows it down? I mean, we haven't used abatacept for so long.
In our experience, I guess the first abatacept use, it was like 10 years ago, and
It happened anyway, or?
Yeah. And when it is already here,
You can't really ameliorate it, right?
yes,
Do you use FibroScan?
yes, indeed, for the
FibroScan, do you use that, the FibroScan?
Yeah. But
Do
actually,
you use the
to be
FibroScan
honest,
Yes.
as well? Yeah.
yes, it could be helpful.
Maybe.
For the diagnosis, you need the biopsy, but for the follow-up, you can.
And for the doses for abatacept, what do you do in your practice?
I guess it's 15 milligram per kilogram
That was
per
twice
twice
a
a
month.
month.
Yeah.
Every 2 weeks or every week?
Every 2 weeks.
we give it every 2 weeks.
2 weeks for you?
Yeah.
I think we're using it every week, but as I say, my experience on that is much less than yours.
Subcutaneous, it's really.
She will have the she
She will have that.
she's having the subcutaneous.
So you can do it weekly at the same dose, at the same equivalent dose.
Okay.
The other thing about, in her case, I was thinking her nutritional side is
Yes.
probably very weak.
Yes.
And I was actually chatting with her about calcium. I imagine her vitamin D is low.
Yes, we are doing supplementation, but she are losing it.
She loses it.
Yeah.
I imagine.
For
I think
probiotics.
for the term, I think
Absolutely.
trying to get many patients with this immune dysregulation associated with GI disease with severe diarrhea, and it didn't work. So you give it on ascending doses, but then it's so that might give you some nice look on the patient that is happening. And then by the time we try to figure out the dose and maybe read a little bit more about whether to know about her liver disease.
Thank you so
She
much.
has to be counseled about that.
And outside this patient, I need also to say that our experience in those patients with LRBA who have hematological manifestations, they really responded very well to the mycophenolic mofetil rather than the sirolimus. To the MMF, they responded well to MMF rather than sirolimus, which was to me very astonishing, but they had a very good response to the
Maybe she needs both.
Maybe.
We can combine the abatacept and the MMF.
Yes.
Okay.
Yeah.
So we can choose it instead of pentasa. Perhaps.
Yeah, instead of the pitasa, actually. Yeah.
Because you tried it before and it didn't work.
Yeah.
Sorry. And what about increasing the infection risk with both
Yes,
of them?
it's an excellent question. We have a patient that developed Mycobacterium chelonae infection under abatacept. Eventually we suspended and we treated Mycobacterium, and then he has the prophylaxis and we maintained abatacept. And there is another maybe red flag is cancer.
Yes, they have a lot of
So this is why
It's a bit risky.
yeah,
It's hard.
when they are young, because she's 25.
Yeah. And you keep them on regular IEI drip?
Thank you so much.
Okay. Thank you.
Thank you.
Primary immunodeficiencies. C'est ça. C'est ça.
Hello everyone.
It's an honor for me to stand in front of you at this congress. I'm Lisa Filali, an internal medicine physician in this university hospital. And before to start, I wanted to point that this case was my first experience with the PhD, and it's also my first time presenting in English, so be kind with me. And I want to thank also Dr. Alawi, who is the most experimented physician in PhD to introduce me to this field. So, I'm presenting the case of Mrs. LK, a young lady aged of 23, who was referred to us by the dermatology department because she was presenting multiple warts involving since the age of 13 and located on 70% of all her body surface, hands, feet, as well as on the trunk and back, which was rebellious to topical treatment and biotherapy. And this unusual, progression of these warts, as well as the chronicity and persistency of them, leads to the suspicion of immune deficiency. So when we received her, we learned that she was from a consanguineal marriage, and she reported recurrent infections since her early childhood, essentially respiratory and digestive. There were no significant family history, and she was not taking any medication other than the occasional antibiotics when she was infected. And at the examination, there was no symptoms other than the skin involvement. So we started with our investigation with a blood count who revealed mildly hypochromic microcytic anemia, leukopenia with lymphopenia at 500, and thrombocytopenia, a mild thrombocytopenia, and the serum protein electrophoresis revealed an hypogammaglobulinemia at 3.6. We did also an immunoglobulin determination that not revealed any defects in the synthesis of immunoglobulin, but the immunophenotyping of peripheral blood revealed a global lymphopenia involving T, B, and NK cells. Obviously, we excluded all the causes of secondary immune deficiency. So we are in front of a suspected of humor and cellular immunodeficiency in this patient who is responsible for a chronic HPV infection that is leading to an important aesthetic problem in a young lady. And we decide to perform a genetic study that is being conducted. So my question for you is if the profile of this patient suggests for you a typical PAD for you, and which one? And to continue with the case, so as we didn't have any other alternative that would compensate the humoral deficiency, so we introduced polyvalent immunoglobulin therapy and prophylactic treatment with regular antibiotics and vaccination to limit the infections, but we need also to control the extension of the skin lesion. So my following questions for you are: how does stem cell transplantation to reset the immunological profile in the patient fit into the management of this disease? And if we succeed in detecting a mutation, can we expect to introduce a targeted therapy? And thank you for your attention. It's short, but I had these questions.
I want just to tell you that your English is perfect, but
Yes,
you have to speak rather not too fast for us, the beginners. But I am so surprised, and I want to tell you, We have questions for you, not you for us.
It's my first case with VA. That's why I pointed it.
Does she have monocytopenia?
Monocytopenia. Pancytopenia.
No, monocytopenia.
Monocytopenia.
Yes.
Wait.
We didn't check. We didn't look for this because normally we have monocytes, but we didn't take attention.
Okay.
I vote for GATA2 deficiency.
Okay.
Do you
that's
have the
good.
answer or?
No, we are waiting for the
Ah,
answer.
okay.
No, not yet. We don't have. We're waiting for the genetic
It's
study.
ongoing.
We are waiting for it.
Did you histopathology?
But if you have monocytopenia,
Okay.
it's quasi
More likely.
GATA2 deficiency.
That's no. Okay.
It's a very good hint.
Okay. Okay. We're looking for it. So
How about toll-like receptor failure deficiency?
And you're looking for something that's going to be homozygous defect, yes. Considering the family history, that's the more likely option, not something dominant. So, women would be out. So many things would be probably not in the running here based on that.
Okay.
No family history.
No, there was no family history in this case.
Does she have lymphedema?
No, at all. Only this skin involvement and
If she was having it?
what's implicates GATA2.
Yeah.
Let's not talk about this after.
Great.
Yeah, GATA2.
WIM, I don't think that WIM would explain
I don't think WIM goes here.
thrombopenia and
No, it wouldn't explain it.
it would explain.
Plus hemoglobin normal, right? You said no.
Sorry?
Normal, hemoglobin is normal.
Yes, that's it. There was no deficit.
Yeah,
Okay.
it doesn't fit very well.
The IGE neither.
I think that stage 1 gain of function mutation is more associated with the candidiasis infection
That-
rather than
okay. Okay.
Think about transplanted, she's fairly well.
For
So
her.
I hate to bring her a new problem on top of this one
Okay.
Unless
until you know a little bit more about the genetics. When do you get
So-
the genetics back?
We don't have.
When do you
Don't
normally, when do you think you're getting it back?
We don't know when we can receive the results of the study, the genetic study.
No, because we didn't do it here. It was done in France.
It's sent to France.
So sometime within the next 2 months, 3 months, 4 months,
Yes.
6 months?
We don't have many experience with this, so we can't really know.
it's less than 1 year.
Okay.
They didn't respond to us yet. I don't know why. Perhaps it was a discovery. No. I think it's a novel mutation. And yeah, they are checking for it. Yes. Yeah.
Which time is it? It's in Russian.
Yes, yes.
She has like 3 or 4 months delay.
Okay.
And I will give you the number.
That's a good idea.
Yes. To check for it.
That's the best idea. That's the best.
And I can take the blood if you
Yeah.
want.
To recheck for it.
Yes.
Yeah.
Or,
She needs that panel, she needs the entire
Mhm.
panel,
Yes.
because it's really
I
hard to
think that
do one by one by one, it's
That
probably,
was the idea because it's very
Yeah.
interesting and
you
that's
know,
the
you
reason that we sent it to them.
get
So
a
we
big
you
panel,
wait for it.
A big panel.
because you don't know in advance.
Yes.
I mean, it could be Bear lymphocyte syndrome as far as I know.
yeah.
You know, it could be anything, it could be Artemis, could be basically anything here.
Mm.
And why did you suggest hemorrhagic syndrome?
No, it was another in the literature only the case who came with warts, skin lesions, extended wear lesions.
You mean dog 8, not hyper IgE, not the front.
I know.
You mean the dog 8?
Dog
Yes.
Dog 8.
But yeah.
It's just guesswork isn't gonna help you here.
What is a little bit worrying is the thrombopenia, since GATA2 deficiency, if it's a GATA2
What do you think of stem cell transplantation in this case?
It depends on the bone marrow, I guess.
I think it depends partly on the bone marrow, it depends on what the gene effect is, because some of them are more likely to run into deeper trouble than others.
So maybe we'll have to
You don't want to
use
use that first.
not
Yeah,
not
that's
have
nice.
to see more clearly.
It could be antibodies against autoimmune, against cytokines.
I think this is more systemic, I think this is an inborn
Yeah,
consanguineous, homozygous.
We know that
of some
it's
sort.
involved because they have a gene, but they just don't know
Okay.
which
The
one.
precise.
Functional, if you
I
could
think.
help them get that, catalyzed, it would really answer the question before
Yes,
the end of the year.
Always have the main
That's great. That's the best thing about this field is the networking, you know that?
For sure.
Have you access to HPV vaccination?
Yes, it has begun this year in Morocco.
So you
We
can try
can hear from
vaccinated wards. It could be.
You can try it, but I don't think it's gonna add anything.
Okay.
Of course, you're gonna probably do it, but we've done it as well on ours, with very bad
And
works. Nothing.
yeah, because they have, I think,
Depends.
Yes,
We tried. We
I
tried.
mean, her issue also will be genital issues.
Yeah.
We're not going there at this moment.
Sometimes in dermatology, they inject BCG vaccine for the warts, yes. And it sometimes works, it's not 100% perfect, but it sometimes works.
This year to inject the BCG vaccine, you can see such T-cell effect.
you can have
I don't listen to sorry.
Is patient I asked she was tested for a stage 3 mutation because yesterday it was a similar case with stage 3 mutation.
Loss?
Yesterday,
Loss or
Gain.
gain?
Loss of
Loss of function or gain of function? Gain de fonction.
We don't know. We expect for the genetic study and we'll see more clearly what's
yesterday was
happening.
a similar case with stage
Yes, with
3
vulgaris
mutation.
words.
Isolated again from pure vulgaris.
Maybe. Maybe. So thank you for coming. Thank you.
This one. You can do the panorama.
It's not on?
It's PDF one. It's PDF. It's PDF. It's not PowerPoint.
It's not on.
PowerPoint. Like this. The format. The format. It should be like that. The PowerPoint.
That's why this is not sent like Anyway, you can project it or no?
I don't think so. Like that.
We have issues with it.
لي شو اللي كاين هذيك PDF reader فين PDF reader ما عرفتش فين
اللي قاعدة هنا تعرف اللي كانت هنا
فين هي مشات
Tout le monde est là. Notre équipe est là. Le président, le chef de service. Je suis le chef de service, c'est moi. Écoutez, on va bientôt s'éclipser, ça va devenir
In Morocco, it's women
80%.
from that run the medical wards. Yeah, yes. We are, we have many chief of departments. More efficient.
ما كاينش PDF reader
Doesn't happen in
It's regular. XLA.
شي ما عندهمش PDF reader عندهم غير هذا
كانت مشكلة نحط السكرين هنا ونشوف.
فين هو هذا
Just for curiosity. There's a male predominance on the thymoma.
هلا
What do you think? I mean, it's curious.
أنا أسأل
شوف ميكرو
There's more guys.
هو هذا هو هذا
بس هو ما في بروجكشن ما يطلع بروجكشن
خصو نورمالمون خصو يطلع
يعني تحط على
زعما
الديسكتوب يعني ما يصير؟ خلاص يلا مو مشكلة حط هذا هيك
هذا يتقلب صغير
ما it's not a big
It's not like I didn't see a female with syndrome. I have a few, but they're just the predominance of males.
خلاص ما في مشكلة
One of my patients is an endocrinologist. You know, curious thing is, I don't know if you see this or not, but I have
لازم المستطيل المساعدة
so I think he's a good supplement. Because when you see somebody and all of a
صح؟
sudden
ولا مش هيك كيف اقرا؟ كيف اقرا؟ ولا خلاص خليني انا انتظر without this. خلاص خليني انا ادرس.
no one crashes in 10 minutes.
Okay, good afternoon. Sorry, we couldn't upload it. We have some technical issue. It's a short case anyway, so I will just say it without the presentation. So basically, M is a 37 years old female. Yeah, I know it doesn't
Not
work.
working.
Yeah.
So she's doing
Sorry.
it. Very loud.
Yeah. Huh? Yes. Okay.
We can take more 5 minutes to
Okay. Sure.
solve this.
ما عندهمش PDF reader ولكن عندهم واحد اللوجيسيال اخرى
لا تا هو ها هو PDF خصو يدير لي بروجيكسيون
فين هو البدء
هو هذا اللي كنحمل هو هذا
هو هذاك
ها هو هو هذا ها
Okay, so good morning. My name is Dr. Iman Al-Salahi. I'm from Kuwait. I'm a pediatric allergist, but I see both adults and kids in my private practice. It's not a primary immune deficiency case. It's query HAE, but we'll see what you think. So basically, M is 37 years of age. She's a female. She came to my practice after she's been suffering for 4 years. So she was having lip swelling associated with cracked lips, redness, and irritation on the area around the lips. Sometimes itching, but not a lot. This occurred every month, usually a week before the menstrual period, during the past 4 years. Prior to the 4 years, she only had eczema on the hands, but nothing on the face. Before she came also to see me a few months ago, she had seen several physicians, including dermatologists. They all prescribed either Leukoid, which is a topical steroid, or Elidel, and she only have a very minimal improvement temporarily with no effects, hugely effect. Antihistamine doesn't help in her case. She had no tongue swelling, nor throat swelling, no pain sensation, no abdominal pain. She doesn't have any issues when she go to dental to do any dental procedures. Family history, her sister, she just recently developed atopic dermatitis a year ago, and recently her eczema also flares just around the period of time. No history of consanguinity. She had mentioned, but vaguely, that her mom sometimes have a tongue swelling, but she didn't rely more on it. Otherwise, no consanguinity. So basically, I wanted to rule out HAE, and I did C1 esterase inhibitor twice. The first one was just borderline low. I repeated it, and it was normal, and the function was normal as well. I did the C4 was also normal, ESR normal, and then basic CBC and just LFT, RFT all normal, just as a basic workup. So in terms of triggers, she is not relating it to any lipstick, wearing lipstick or nail polish, not associated with any hair product or hair dye, not associated with any specific food. And as I said, specifically comes around 1 week before the hair period. So the question is, what could it be? Could it be HAE with a normal C1 esterase? Could be the type 3, which is usually around female, the period time with hormonal changes. We need to do a genetic workup to see if there's any factor 12 mutation or not. The other thing I was thinking, could this be a new entity, something related to atopic dermatitis only with hormonal changes? It's weird that her sister also starting to have something similar to it. So I don't know if you have any suggestions or any ideas. Just kind of, I tried antihistamine, as I said, not working. We tried to put topical steroid around the period time, but again, not improve at all, just minimal improvement. But the swelling is, I don't have a picture unfortunately, but it's obvious. So it's not kind of a mild atopic dermatitis, it is a big swelling. And that's what I thought initially of HAE.
Do you have access for genetics?
We don't have in Kuwait, but we usually send it abroad. So that's why I kind of we have issues now. But that's my next step to send.
Because some of the patients with HAE, having an atopic dermatitis doesn't exclude having an HAE.
Exactly.
You could have both.
Yes.
So I'm with that she's an HAE patient.
Yeah.
And have you tried doing the C4 during the attack and in between the attacks?
No.
But because it's during the attack, if it's an HAE, definitely it will be low. So you can do both.
But type 3 will be normal too.
Yeah.
But it's a good idea. I will
Try it.
try to do it before the attack. I don't know what else to think about.
And no bleeding diathesis or something?
No.
Nothing to do
No,
with
just
it.
irregular periods.
Because we have two little boys who had going angioedema.
Mhm.
C1 esterase inhibitor level and function were both normal. And they also had this bleeding thing. And then they had, they did not, we did not do genetics for them, but definitely they had a factor 12 issue.
Oh, really?
Yeah, and we think it's an interesting one that we need to send somewhere to get them checked. And they are brothers, so little.
Could it be the other type, because of a chronic infection or autoimmune disease that causing the C1 esterase to be low, not necessarily genetics?
And that's the other thing, that your function here is normal, and you check them during the attack.
Yes. No, well, just a random. She wasn't having the attack that time. But we can do it
With
again.
inhibitor,
type 1 or type 2?
Yes.
Yeah,
and
type
then
3.
Type 3. And with other things. Obviously, you can go as far as trying things like
As a treatment, you mean? I don't know. I maybe want to.
That's a funny story.
Yes.
Once we had this patient sent to us because of immunodeficiency, and we found that he was actually on methotrexate, and then we asked why are you on methotrexate, and they say because we need to get his child to get these recurrent swelling. So he was actually given methotrexate for angioedema, and angioedema went away. That is the mechanism. Exactly. But then he also had when he came, we found that he was having pictures of okay.
But you don't want to give immunosuppression and then go into another problem, I guess, right?
So methotrexate takes it away, but that's not
Yeah.
the suggestion. But it is in the literature with idiopathic angioedema. You can go as far as in the same direction. You go with idiopathic urticaria.
And what's her response to steroids and antihistaminic?
No response to antihistamine. It's topical steroid minimum, like temporarily relief, but not long.
I don't think it is going to work locally because it's obvious that whatever is triggering it is more systemic.
Right.
If it's hormonal,
I was thinking maybe to put her on oral contraceptive, but you know, I thought maybe just to send for genetic first and then try this as an option. Sorry?
maybe speak to the gynecologist
Yeah.
about what should be different.
Yeah, right.
She's married, is she?
No, single. What that will does it?
No, it's just because of the cultural thing
Yeah.
back home.
Okay, well. But you don't agree that could be some like a
Something
different
that-
entity, like maybe if it's normal factor 12, maybe could it be something new?
Have you tried tranexamic acid?
No, nothing tries to be honest.
Why don't you try tranexamic acid? It works. Yeah, it does
Really?
work. Even with even
Okay.
minimally with
Yeah,
periodic
but then-
angioedema.
Yeah.
I said yesterday, ceramic acid.
So like just like doing her like 1 week before her period, get into the hospital, get a dose and go. Like that's what you're trying to say, right?
Yeah.
Yeah. Okay.
If that's the only time that she's going to
Yes,
get it,
only
yeah,
like
why
1
not?
week before her period. Yeah.
Try tranexamic acid. It does work. It
Yeah.
might not be nice on the start to start with,
Mhm.
but then start her on a very small dose, like
Yes.
0.5
Mhm.
milligram or the 500 microgram, then
Yeah.
escalate that. You have a margin of up to 3 grams a day.
Mhm.
So you can do that, see how far she can go.
I
You
think
can start
better
with
than
a small
methotrexate.
dose, up to 2 grams, they're usually okay.
Okay.
They're usually okay. They don't really
Any other thoughts?
Is she having any drug which can induce it?
Drugs? No. She's otherwise healthy. She's not on any medication. Yeah. But you mean like antihypertensive? Yeah. No.
Like contraceptives?
Do
No.
complete exploration, systemic exploration.
Sorry?
You have to do a systemic exploration of all the anticorps. Sometimes in dermatite atopics, we have DSF 70, comment on dit là? DSF 70. Yes, donc un anticorps antinucléaire plus souvent positif.
There was nuclear antibody, but it can be seen even in healthy populations. Healthy patients. It's not very specific.
Anti-NA? What kind of
It's
say?
a nuclear antibody. It's
Nuclear
DSF
DSF 70.
Okay.
Can do it.
As underlying like rheumatological disease, like you want to figure out, or what? Like what's the purpose?
It is related to atopic
Yes,
dermatitis.
c'est 80% des dermatites atopiques ont un DSF 70 positif. D'ailleurs, parmi les étiologies, il y a les anticoagulants et les 70 positifs, 80% c'est dermatite atopique.
With some atopic dermatitis, 80% have
Yes.
this antibody,
Yes.
which is positive.
Oh, okay.
Voilà.
So it's like a blood test, just a blood test?
It's
Yes,
just
yes,
yes,
yes.
it's like nuclear antibody.
So that's just like, so what, it will help us what, diagnose or atopic dermatitis or like what's?
Yes,
I
it's
don't
for
know.
atopic dermatitis, and it's the idea to start something with autoimmune efficacy if it is positive. But the problem with DSF17, it is positive in healthy
Oh,
patients.
false positive,
Yes.
Okay.
Just
Thank you.
say one last thing
Yes,
about this,
go.
because angioedema is a very common thing that
Yes.
happens. You said that her lips break.
Yes, like so she have lip swelling and then break and like crack and redness.
Could
and
that be
yeah.
facial granulosis? No, because that lasts.
You don't
Stays
have
longer and she gets.
So she just did it like for a week and then disappear and she's
It
fine for 3
disappears
weeks.
completely,
Exactly.
okay.
And then she comes
I think you
back.
should try tranexamic acid, and I think you may not want to do genetics yet.
For factor 12 even?
Yeah, yeah. Just try the tranexamic acid and then see how things develop.
I think also maybe I would send for both her and her sister since her sister is starting to have something similar.
She doesn't have facial paralysis.
No,
No.
and no rash, no urticaria, nothing. Mastocytosis? No, mastocytosis they have rash.
Rash, yes.
Or anaphylaxis, yeah.